but, and again, and then it translates into things as simple as being proactive. I mean, in hospital stays, what's your DNR status for patients, you know? How do you manage them when they are admitted? How do you manage them if there has to, how do you manage all those things? And then, as you mentioned earlier, if patients decide to go on the hospice benefit, whether it's outpatient or inpatient, I mean, part of doing that, you know, it precludes you from seeking other types of treating care, as you all know. So has to be, so then a lot of times, like a lot of the specialists will wash their hands of you. You know, you think it, so. You've got to have that quarterback, which either be the primary care doctor or the more sophisticated case or environment will be the palliative care physician, who may also do primary care, but you may have a dual role in some cases.
Okay. So
did I answer your question?
Yeah, you did. Yeah. So I think what would be helpful now is you talked earlier about how you used to have the hospice practices, you used to own those, and then that went away. Could we just kind of walk through that a little bit? What happened?
Sure.
What
yeah,
caused
so
the shift?
Hospice, I mean, there are some big companies that do hospice, but I mean, it depends on the state, and you're probably familiar with the players. But you know, it used to be, you know, you saw like the holy grail of post-acute care. You had the home health, hospice, and then some type of like skilled something, right? I mean, this was like, and so these companies, Gentiva, and some of the other ones I'm failing to remember. You know, you have big companies that have kind of jumped into all these spaces. So you have that, and they're the ones that I think really sophisticated the business, in my opinion, and began to actually learn how to run it efficiently. Well, you have that coexist with like tons of mom and pop shops and tons of physician-owned hospices and home care, because like, heck, we're the ones making the referrals. Heck, you know, technically the patient has to have a choice, but I mean, I guess it depends on, you know, how you provide that choice is always an operative decision, right? But then, you know, our vision to be a full IDN was to, you know, own everything from cradle to grave. Well, I said grave is probably a little cradle to morgue. How about that? You know, so sorry, it's a healthcare joke. We're not. It wouldn't be good for us to be in the seminary or the cemetery business, and anyway, it wouldn't be good. But but here's the thing. I mean, what we've learned is, I think a lot of people are learning this, unless you have a core competence here and have focus and really tight compliance, you can being a jack of all trades is not, it's to all markets is not necessarily the most efficient thing to do. So we're evaluating service lines and businesses. This is one we were losing, and it could have been because of poor leadership, poor execution, you know, just poor clinical product. And so really it wasn't one that we had been able to run successfully over a period of time. We're being forced to look at our cost considerably. And so in areas where there was also a proliferation of other hospice providers, in our case in particular, there were a ton of hospice providers. They're doing a whole lot more efficiently than we were doing it. It was taken away from our core business of focusing on running practices in hospitals. We're going to get their at-risk lives anyway. Since we have the hospitals and have the physicians, we're going to get those at-risk contracts. Our new hospice providers are going to get at-risk contracts because they don't have a comprehensive enough product offering. So it really became a decision, unless you had a really good, sound business already functioning, knowing they weren't that big of a threat because there's a lot of them, and we weren't competing well with them, but we're going to ultimately get the lives. We're going to get the lives, and we're going to be able to contract with folks who think can do a good job at a reasonable price to cover those lives, and we can focus on really getting the right patients into hospice versus just filling the census, if you will. You know, all those are probably 4 or 5 factors, and there are probably others I'm forgetting. And we did keep it in some markets, if I'm not mistaken, outside of my market, only because it was a different environment, much better run, better density. We don't have better density that you can kind of align services. So it was just a market by market strategic decision based on what the market needed. And again, since we're going to get the covered lives anyway being at risk,